Great pleasure to have in the podium Maria Lorenza Muiesan, combination therapy in arterial hypertension.
Thank you, Professor Fabbri, once again for the invitation. I'm really happy to be here. I learned a lot of things yesterday afternoon and this morning. And I will start talking about combination therapy in hypertension, just reminding you the importance of high blood pressure as a leading now risk factors related to death and to disability. The Global Burden of Disease study has analyzed the changes in risk factors from 2000 to 2013. And as you can see, high blood pressure has gained one position, the first one. These are the numbers related to the presence of high blood pressure all over the world. And obviously, there is the demonstration that the lifetime risk related to the presence of hypertension is extremely important and significant for several cardiovascular diseases, going from ischemic heart disease, acute or chronic, to heart failure, preserved or reduced heart failure, function, and cardiac arrest and sudden death, cerebrovascular disease, ischemic or hemorrhagic, and peripheral artery disease. The important thing is that all the studies that have been performed up to now and have been analyzed in several meta-analyses published in the last year have shown that if you are able to reduce blood pressure, you can prevent cardiovascular events. This is one of the last one published on The Lancet in December last year, and you can see that for 10 millimeters of mercury reduction in systolic blood pressure, you can prevent about 20% of major cardiovascular events and coronary artery disease, and 30% events related to stroke or heart failure. So there is no doubt that you can do something really beneficial by reducing blood pressure. And the more you reduce blood pressure, the greater is the advantage and the benefit that you are gaining. Unfortunately, the awareness, the treatment, and the rate of control of blood pressure is not the one we would expect in consideration of the previous data. And in this study, published some years ago, it was quite clear that in all countries, independently from the income level, the awareness and the treatment of blood pressure, increased blood pressure, was not the ideal one. And the proportion of patients that reach blood pressure values lower than 140/90 was around 40% in the better of the cases. So we need to do much better. This is not all over the world, but even in Europe, in this Eureka study analyzing the blood pressure control in all the nations, in some of the nations across Europe, you can see that the mean blood pressure control is 39%. And the real risk is not very clear to everybody, since in Europe, in secondary prevention evaluation of ischemic patients, patients with previous myocardial infarction, the rate of subjects with uncontrolled blood pressure is around 40% or greater. What about Italy? These are the clinical data recently published from our society, analyzing what has been collected between the years 2000 and 2011. As you can see, the rate of patients with a controlled blood pressure is around 34%. Fortunately, things are going a little bit better because these are the results we have obtained during our Hypertension World Day. And we were able to show that in the last period, an increase in the rate of subjects with low controlled blood pressure was slightly higher, reaching 50%, not really higher than that. And obviously, this goes to the consideration that much more attention to what the guidelines are suggesting to us should be taken into account, because what guidelines in 2013 do remind us is that the main benefit of antihypertensive treatment is due to lowering blood pressure per se. So we should really treat patients, identify them, and treat them going to the goal blood pressure. And we could choose among the 5 classes that we usually are suggested to prescribe: diuretics, beta blockers, calcium antagonists, ACE inhibitors, and angiotensin receptor blockers. How can we manage the hypertensive patient? When we have a grade 1 hypertension, we obviously start by lifestyle changes for several months, and if there are only 0 or only 1 or 2 risk factors associated, we should wait several months before treating the patient and stick to the lifestyle changes. If lifestyle changes are not enough to reduce blood pressure values, we should start treatment. And treatment can be decided according to this algorithm as monotherapy, which is suggested only for patients at low moderate risk, or combination therapy, which is suggested as first-line therapy in those with marked blood pressure elevation or with high or very high cardiovascular risk. And the suggestions of guidelines is to moving always from a less intensive to a more intensive therapeutic strategy if the goal blood pressure has not been previously reached. What is the situation in Italy? About 40% of patients are, according to the data we collected in our, with the general practitioners and in our specialist outpatients clinic, the patients at high or very high risk are about 40%. So in this percentage of patients, we should start with a combination therapy. While combination therapy, because it seems quite obvious, 2 drugs are better than 1 and 3 are better than 2, if the combination is rational, and you can reach an effective blood pressure reduction when you give together 2 classes of antihypertensive drugs rather than 1. And there is the evidence that if you add any class of drug to a previous one, you gain a better control of blood pressure than doubling the monotherapy. So there is no reason to increase very much the maximum effective dose of drug if you can add another one and obtain a beneficial effect. Another point is the timing of blood pressure reduction. There are data from the value study showing that if you are able to reach good control in blood pressure, you can influence the long-term outcome. And so it's important that with a combination that in this case was obtained by combining a direct renin inhibitor with a calcium antagonist, the control of blood pressure can be reached earlier than with monotherapy and a later combination of the two. One other point which is very important is the use of a fixed combination versus a free one. In this study, you can see that the use of a combination, doesn't matter if fixed in a single pill or a free one, the better blood pressure control was significantly higher as compared to monotherapy. But if you can look at the two odds ratio, you can see that the fixed combination seems to be better than the free one, because this is probably associated with a greater adherence of the patient to the prescription. And this is probably true because analyzing adherence of patients to treatment by the measurement of medication possession ratio, you can see that the one in a fixed combination, the single pill combination, have a greater medication possession rate as compared to those with a free one. The most important point that would convince us to use a combination and possibly a fixed combination are the data on outcomes. These are the one obtained in the Regione Lombardia. The database has analyzed a huge cohort of hypertensive patients in the region where I live. And you can see that the combination therapy use is associated with the decreased incidence of cardiovascular, coronary, and cerebrovascular events as compared to monotherapy. And this is clearly evident. If we look at the use of fixed combination therapy as compared to monotherapy, both at baseline and during the follow-up, you can see that the best result can be really seen, observed, and obtained when the combined therapy is started and is continued throughout the time during the follow-up, and no switching from combination to monotherapy or vice versa are obtained. How can we combine our 5 classes of drugs? The guidelines suggest to use a combination of the RAS blocker with either a diuretic or a calcium antagonist, and most guidelines published after the European ones do really suggest to start therapy by a RAS blocker, by a combination with a RAS blocker or a calcium channel blockers in most of patients, unless there is a specific indication for other conditions, as target organ damage, as LVH, atrial fibrillation, in which beta blockers should be used to control heart rate, previous myocardial infarction, or heart failure, as you have heard by Professor Cecconi. There are some new data in patients with resistant hypertension. That means uncontrolled blood pressure with 3 drugs, RAS blocker, diuretic, and calcium channel blocker at maximum dose. The use of spironolactone seems to be the most effective one to have a further reduction in blood pressure as compared to an alpha blocker or to a beta blocker. And among the new drugs that have been suggested to be used not only in heart failure but also in hypertension, there is the LCZ696, the ARNI, which, as Professor Cecconi has already told you, is a combination of valsartan and sacubitril, an inhibitor of the endopeptidase enzyme. which has been shown to be particularly effective in reducing blood pressure in hypertensive patients, both by clinic and 24 hours blood pressure. One little point about the blood pressure goals. As you probably know, there has been a lot of discussion in the last months about which is the best goal to be reached. The 2013 guidelines had suggested us to reach systolic blood pressure lower than 140 in the majority of hypertensive patients, and a diastolic blood pressure lower than 90 millimeters of mercury in almost all, except for diabetics. But at that time, the question about the optimal office blood pressure values for patients to be achieved by treatment was raised. Just to address the point whether demographic or clinical condition could influence the choice of the blood pressure goal. And some data that seems to be interesting to this regard are the one of the SPRINT study. The SPRINT study has included about 10,000 patients with a systolic blood pressure in treatment of 130 millimeters of mercury and an increased cardiovascular risk, no diabetic patients. And the aim of the study was to compare a more intensive goal, lower than 120 millimeters of mercury of systolic blood pressure, versus a less intensive treatment, the standard one we are suggested by the guidelines. And the study results have shown a significant reduction in cardiovascular events of 25% and in mortality 27% by intensive treatment. There are still some doubt about these results, but what has been shown is really that the use of combination treatment, which was at least 2 drugs in more than half of patients and at least 3 drugs in a quarter of patients in the standard arm, increased to 86% of patients treated with at least 2 drugs in the intensive arm, and more than 3 drugs in half of patients in the intensive drug. So this is a clear indication to use combination treatment, no doubt about it. And what were the drugs used? As you can see, RAS blockers, diuretics, calcium channel blockers, and also, despite to a lesser extent, beta blockers. Now, these data, as suggested by the president of our society, need really to be discussed, because there were some doubt about the effectiveness in stroke prevention during this study by intensive treatment, but for sure, they suggest that a greater use of combination drug preparations, probably the one with a fixed combination of 2 or 3 drugs, will be the future for the treatment of hypertensive patients. Thank you for your attention.
Elgo.
Yeah.
Then Giovanni.
Thank you very much for this very nice overview. Do you consider obstructive sleep apnea in those patients where you have difficulties to control blood pressure by the appropriate drugs?
This is a very interesting point, and obviously OSAS has been considered a risk factor for worse control of blood pressure. Is very often associated to greater target organ damage, left ventricular hypertrophy, aortic stiffness, and renal damage. So, and the other point is that is probably associated to a low renin status, an increase in aldosterone secretion and hyperaldo clinical picture. So really, yes, it's something we are very careful to evaluate. Yeah.
Giovanni.
Thank you for your exhaustive and very balanced talk. I have a very naive question. Thinking about the role of anti-aldosterone in resistant hypertension, and thinking about the fact that we don't need to have 2.8 or 3.1 of potassium concentration to think about hyperaldosteronism. Maybe we are treating a lot of secondary hypertension in that group. Would you comment on that, please? Thanks.
Yes, obviously, the diagnosis of primary hyperaldo is a very complex one. The one comment to the SPRINT study is that we cannot exclude that at least a portion of those resistant hypertensive patients could have been primary aldo. So the use of an anti-aldosterone drug could have been particularly successful in those group of patients. Nevertheless, if you combine a small dose, even a small dose of anti-aldosterone drug to a triple therapy, you can reach an advantage in terms of blood pressure reduction and target organ regression. Yeah.
You made me curious about the results of the SPRINT study. I mean, what the concern? What the results and what the concern? The open questions.
The concerns are that several studies, at least in some groups of patients, did not show a particular favorable effect by reaching very low level of blood pressure in the past, such as, for example, diabetics. So, for systolic blood pressure, I mean. So the guidelines had changed from 2009 to 2013, saying be happy with when you go below 140, don't run to go lower than that. And the concern for the SPRINT study is that since a stroke is probably one of the events more strictly related to the increase in blood pressure, such an intensive reduction in blood pressure obtained in the intensive arm of the SPRINT study was not related to a decrease in stroke.
Yeah, but then the fundamental question that we all have in using combination therapy, the philosophy is to use the lowest component of each treatment to achieve the best results, or to use the highest tolerated component to achieve the maximum effect? You are lowering pressure, we are improving lung function, but that's the question.
I think that just to minimize side effects, which are anyhow not increased by combination treatment, are really, but to minimize actual side effects, you could start with a combination of a low dose and then increase and get to the highest dose tolerated and effective in reducing blood pressure. Because sometimes you see patients in monotherapy with very huge dosages of any kind of antihypertensive class of drug without any reason, because there is no response in terms of reduction in blood pressure with increasing such an increase in dosages.
Thank you very much.
Thank you.
Thank you.